thanks very much, Peter, for joining us. The technical issues aside, which result in you having to wear some very attractive headphones, sir. But really good that you could take the opportunity to just have a look at these diagnostic profiles that we produced out of the wDST, and wondered what your kind of thoughts were in the first instance, maybe around the lack of diagnosis on discharge from inpatient units. I wondered what your thoughts were around that.
Thanks, Tim. I'll just take a step backwards, and I was just thinking about the process for thinking about these. Like the first one we have to cover off is the data accurate? Like, was it extracted accurately? So we just kind of want to check on that. Like, that's what we do at our service. Do a check, go back, check it again. If that's it, if that has been put accurately, this is what it is, then there's some really interesting questions here between the inpatient ambulatory. And so starting with no diagnosis recorded that you're interested in, it's 10% of those being discharged from our community services having no diagnosis recorded. Now, that could well be, in fact, that upon assessment, there was they didn't meet any diagnostic criteria. So it could be quite okay. But when you look at the inpatient and you find it's 13%, that's actually quite surprising. You have to go through a reasonably high bar to get into an inpatient unit. So I'm kind of quite surprised that, in fact, 13% of those discharged from an inpatient unit have no diagnosis recorded. And so I'd be kind of wondering, does this vary between states and territories? I know we can't do. I know we can do that at the national level. We can't do it at a service level at the national level. But I'd be wanting to actually think, if I saw it's 13%, what does it look like for the inpatient you're not connected with? And I'd be pretty concerned if we've got practice that allows 13% of those discharged from our service to go into our unit and be discharged and still think they don't meet any criteria.
Yeah. So that'd be worth kind of exploring at a local level. But we could also kind of nationally looking across jurisdictions if that kind of number varies. Because
I think if you ask people, everyone would say, oh no, we're taking the most severe, complex, acute presentations to our inpatient unit. This actually, diagnosis isn't everything. But a lack of diagnosis says there is something really odd happening somewhere about who's getting into these units. The other thing you'd be really interested in is, sorry, Tim, put this against the HANOSCA data. Because if there really is no diagnosis recorded, gee, you expect to find very few symptoms appearing on their HANOSCA. And my money says it's not going to be like that. In fact, HANOSCA will be showing some quite severe symptoms happening. That's what got people in. So what's going on here? This is how we've turned out.
Yep. No, that's another fruitful line of inquiry. I wondered if you had any comments to make about the general profile of the diagnosis, either an inpatient or an ambulatory, the kind of the mood, anxiety, and adjustment component of that.
Sure, of course I do. It's always interesting when you look at these profiles, and this is what inpatient 19,000 discharges. So that's a pretty sizable database. It's very hard not to compare it with what you know in your own neck of the woods. And so I won't try and avoid that, but I think that's true for all of us. The first thing we should be doing is saying, well, how do we look compared to this national profile? Are we overdoing certain things, underdoing other things? Look, with this, inpatient-wise, first up, mood being 27%, I think that's what you'd actually expect to see. You've got a lot of very severe depressive presentations falling into that category. A lot of self-harm and risk and suicidality is going to get you into an inpatient unit. It's going to be not surprising that the mood's probably going to be there. Anxiety, much smaller. Eating's an interesting one because to some degree it raises the issue of what sorts of inpatient units does a service have in its configuration. For some of our presentations, we would use the adolescent unit, the psychiatric unit, but for other eating disorder presentations, we might be using pediatrics. So some of those disorders are going to spin off for their inpatient care in different directions. Personality is quite that surprised me. That's quite low, the inpatient. And I do wonder whether, in fact, mood is being used as a flag. And if you delved into it deeper, you actually find there's a number of people with a personality disorder diagnosis being admitted, but who also have a mood disorder, and that's what's being flagged at this level.
Right.
Psychosis, here's a really interesting jump for me here. Psychosis, 9% of the discharges, people have psychotic disorder. Okay. Yeah, that's, that doesn't surprise me. I think it could be a bit higher in places. But when you go to the ambulatory, it jumps back to 1%. And at first, this sort of seemed really a bit odd. If the tertiary mental health sector is not actually seeing people with psychotic disorders, who's seeing them? And then I thought, this is CAMS material. So it might be, say, for example, a 16, 17-year-old in the community, they may be getting treated in early psychosis team. That may locally be managed by adult mental health, in which case they won't be appearing in your data, the way the national data is worked out. Or they may be being managed by Headspace. Some of the federal monies went through to earlier psychosis response not to the public mental health sector. But I'd kind of want to know that we're not losing these people, first and foremost. So that's my hypothesis, is that they're actually appearing in a different service configuration. Locally, it would make me want to say, if the proportion of those with a psychotic disorder in our inpatient unit looks more than those in our community teams, I just want to know where the discharges are going to and where that's happening. I'm on the ambulatory profile now. Anxiety, mood, I'd actually expect them to be a bit larger, I've got to say, than that. I expect mood to be much larger. But I do notice here adjustment and disorders of childhood and adolescence is actually quite high. And so I wonder if there's some variation occurring around states and territories, between states and territories, or even within states and territories, about diagnostic practices. So I know, for example, for us, adjustment disorder is more around the 6-7% mark. And psychosis is much, much higher. Mood's much higher. Personality's much higher. And I'm not sure if that's actually practices, diagnostic practices, or the way in which we're targeting our services. As much as I can think, CAMS is about severe, complex, difficult, that we're a tier 3 service, that there's nowhere to go beyond us for more intensive treatment. So we should be dealing with the most difficult cases. But this raises the question again, like we learned from various benchmarking procedures, that maybe not all services are operating in the same way. Even though the spread of those disorders, I would expect to be happening right across Australia. I don't think Sydney's the capital of anxiety, or Brisbane's the capital of personality, or whatever. So what's going on that we get a different profile?
Yep. So the take home message for me is there's some more work that we could do with the wDST, or people could do with the wDST, to look at diagnostic profiles within states and territories, and see if that's contributing differentially to the national picture. Western Australia is doing something different to New South Wales. Or locally, how does your own diagnostic profile relate to the state or to the national profile? Because we can report both out of the wDST. Pete, I really want to thank you for your time today. It's been very enlightening, and we'll get you back, because you've actually done something that I fully expected you to do, which was to pose more questions rather than answer them. And that's what we want people doing, is thinking about this data and what it might mean for them. So thanks very much for your time today.
No worries. Thanks, Tim. Bye.